Good afternoon, and thank you for joining us for this webinar sponsored by the MONAL on behalf of the Global Consortium for Chemosensory Research. My name is Tristram Wyatt. I'm a Senior Research Fellow at the Department of Zoology at the University of Oxford in England. My particular interest is in pheromones, but I'm interested, of course, in the human sense of smell. So the Global Consortium for Chemosensory Research, GCCR for short, is up to almost 600 members earlier in September, with representatives from 59 countries around the world. And if you work on this subject as a clinician, or as a patient advocate, or as a chemosensory scientist, do consider joining us, and there'll be details about the website where you can find out more details later. In terms of news about the GCCR, our first paper, GCCR 001, is out in Chemical Senses, and the second paper is working its way through the system, still in review. We'll be announcing through the newsletter and on the website and Slack the third paper, all based on survey and other data brought together by the consortium. A bit of news about the management team, the leadership team. Janina Pepino, Professor of Food Science and Human Nutrition at the University of Illinois, Urbana-Champaign, is joining the management committee, the leadership team. And don't know, Janina, if you want to have a quick word about your own interests.
Hi, this is such a pleasure to be here, and I'm very happy I was able to make the link. We just finished a meeting. It's really an honor. I've been interested in the sense of smell and taste since I joined MONEL as a postdoc back in 2001. And I've been working on the field now, more interested in clinical populations. And although I was not planning on working on this type of population, I didn't even know what was waiting for us for 2020. This is a fascinating field and an area where we can advance both knowledge, not only for people that are suffering from COVID, but for hopefully in the future, we could also learn something about the sense of smell and taste in general in people, which we are so behind compared to other senses. So I'm really looking forward to all that we could learn with the help of these people participating in these surveys, and with a great team of scientists and colleagues and everybody in the group, that it is a fascinating, interdisciplinary and really community science to be part of it. So I'm really proud and honored and looking forward to all that we can, accomplish.
Thank you very much, Professor Pepino. So I think we could start moving towards our first speaker. Charlotte Holtford is a senior consultant in a tertiary care center
in
COVID-19 hospital located in Paris, France.
I would like to thank Caroline for giving me the opportunity to share our work on MRI and anosmia in COVID-19 cases. Our team faced challenges, so like everyone else in the world. The medical and nursing staff was spread out around the hospital due to the crisis, and our exploration units were off limits to COVID-19 patients. To carry out this study, Michael and I had to perform tasks usually done by nurses and technicians, for example. We also had to create an alternative testing protocol to bring explorations close to the COVID-19 units and patients. First, I would like to thank. At the start of the pandemic, many practitioners thought anosmia was just a neurological symptom. But With quick recovery of smell in most of patients, we began to suspect that it could be a rhinological dysfunction. I summarized our current thinking on this slide. In one hand, if we consider the neurologic hypothesis, several points seemed relevant. First, both olfactory and gustatory dysfunction were observed in COVID-19 patients. Second, most of the time, no nasal obstruction was reported by the patients. Third, few case reports showed MRI bulb hypersignal. Fourth, coronaviruses are known to directly infect sensorineural cells. In the other hand, if we consider the rhinologic hypothesis, we saw that patients recovered the sense of smell quickly and that case reports showed a complete olfactory cleft obstruction at the onset of the infection. Also, studies on animals showed no bulb injury with SARS-CoV-2. For this study, we included 20 COVID-19 patients. All had reported a severe loss of smell. We compared this group to 20 healthy subjects. We performed olfactory and MRI evaluations. First, the olfactory evaluation included two tests: a visual scale olfactory measurement and an olfactory test using 5 odors. Both were scored from 0 to 10, with 10 being normal. Second, we performed an MRI evaluation. As for the timing, we performed both evaluations at the early stage of the loss of smell in the first 15 days and 1 month later. For COVID-19 patients, we included 10 men and 10 women. The mean age was 34.6, more or less 8 years. None of the patients had associated nasal obstruction, and dysgeusia was claimed by 17 of 20 patients. Typical symptoms of SARS-CoV-2 infection were present in all patients, such as fever, cough, myalgia, or dyspnea. As far as the mean age and sex, no significant differences were observed between the healthy control and the patient groups. For COVID-19 patients, the mean delay between the onset of olfactory loss of smell and olfactory tests and MRI was about 6 days. For the visual olfactory score within a range of 0 to 6, the mean was 1.6. For the odor tests, in a range of 0 to 8, the mean was 2.8, and 5 patients had a score of 0. MRIs found a complete obstruction of the olfactory clefts in 19 of 20 patients. 17 of them had a bilateral obstruction. 1 patient had no olfactory cleft obstruction, but in this case, the MRI was performed 11 days after the onset. At 1 month follow-up, both olfactory scores and MRI showed improvement. For the visual olfactory score, the mean improved from 1.6 to 7.4, and for the others tests, from 2.8 to 8.3. MRI findings showed that 12 of 19 patients with initial obstruction had recovered a normal morphology of the olfactory clefts. A complete obstruction of the olfactory cleft was still observed in only 7 of 20 patients. Just 1 was bilateral. What is important is that no abnormality was found on the olfactory bulbs, and there was no significant difference in olfactory bulbs volume between the first and the second MRIs. On this slide, we can see a graph summarizing the mean olfactory cleft obstruction on the MRI at first consultation and 1 month follow-up in patients with COVID-19. On the left, the blue block represents the mean olfactory cleft obstruction at the early stage of the disease. And on the right, the red block represents the mean at 1 month follow-up. There was a significant decrease in olfactory cleft obstruction between the first, the blue block, and the second MRI, the red block. On this slide, we can see a graph summarizing the mean olfactory score at first consultation and 1 month follow-up in patients with COVID-19. On the left, the blue block represents the mean olfactory score at the early stage, and on the right, the red block represents the mean at 1 month follow-up. We found a significant correlation between the degree of olfactory cleft obstruction and the severity of the olfactory score. Here you can see pictures showing coronal section of the olfactory clefts and bulbs on MRI for one patient at the early stage and at 1 month follow-up. Look at picture A. MRI was performed at the early stage of the disease, and at this time, the olfactory score of the patient was 0. The broken arrows point to the olfactory bulbs, and you can see that the olfactory bulb volume is normal. Just below, the full arrows point the olfactory clefts, and you can see a complete and bilateral obstruction of the clefts. When you look at picture B, this is the MRI performed at 1 month follow-up, and the olfactory score improved to 10. The broken arrows point the olfactory bulbs, and you can see that their volume is still normal. Just below, the full arrows point the olfactory clefts, and you can see that there is no more obstruction of the clefts. Olfactory cleft aspect is normal at 1 month. Here you can see pictures showing coronal section of the olfactory clefts and bulb on MRI performed on a second patient. Look at picture C. MRI MRI was performed at the early stage of the disease for this patient, and at this time the olfactory score was 0. The broken arrows point to the olfactory bulbs, and you can see that the olfactory bulb volume is normal. Just below, the full arrows point to the olfactory clefts. And as we see before for the first patient, you can see here a complete obstruction of the clefts. Look at picture D now. MRI was performed at 1 month follow-up, and the olfactory score was still low at this time, at 5. The broken arrows point to the olfactory bulbs, and you can see that the volume is still normal. Just below, the full arrows point to the olfactory clefts, and you can see that there is still a persistent obstruction of the clefts. In most COVID-19 patients, olfactory function loss is associated with a reversible obstruction of the olfactory clefts. What we can conclude based on our experience is that most of our patients recovered normal olfactory cleft aspects at 1 month follow-up. But a poor olfactory recovery could be associated with a persistent olfactory cleft obstruction. And in this case, I am afraid for the few patients who had a persistent olfactory cleft obstruction, which could lead to abnormal scarring later. In my opinion, I suggest that an MRI or a CT scan should be performed in case there is no olfactory improvement at 1 month follow-up. Potential therapeutic implications had to be pinpointed, especially as we must consider the importance of early nasal irrigation with or without steroids, in addition to olfactive rehabilitation. I would like to thank you for your attention and hope I will be available to connect for questions later. In most COVID.
So, Charlotte explained that she's actually in clinic at the moment and is hoping to join us for questions at the end of the sessions. So she very kindly produced that video presentation.
Charlotte just joined us.
Oh, yes. Hello.
Wonderful. Even better. Okay.
Yes. Thank you.
So beautifully done.
Sorry, but my Wi-Fi connection is not very well because I use my phone, but I could connect to be with you. So I don't know. Is the question are now or after? What do you prefer?
We probably have time for just one question. I'm not sure if we have any. I think we'll gather questions for the end.
Well, we actually do have questions, so let me hop in here. This is from Teresa White to Charlotte, and Teresa asks, did your patients report feeling stuffed up? At least some previous reports seem to suggest that patients are unaware of any nasal obstruction.
Sorry, I'm not sure I understood the question, but none of our patients reported nasal obstruction. Is that what she wanted? Yes. Yeah. First, it's why, the first slide, I talked about the first feelings we had that it could be neurological symptom. And but when I saw patients, because we had to manage a lot of patients with anosmia at the beginning, And we just realized that it could not be neurologic, because most of them had recover all the sense of smell really quickly. So it doesn't look like a neurological symptom. And there was no other neurological symptoms in addition. So we performed quickly CT scan and then MRI to check this. And when we saw that there was no nasal obstruction and no involvement of the respiratory epithelium, but only the olfactory cleft and the olfactory epithelium looks affected. I don't know if it's okay for Teresa.
Yes, I think we have time for one more question.
So the next question is from Nicole Garneau, and she asks, what is the cause of the olfactory obstruction in COVID cases?
It's a good question, but what we think, because some studies had been performed on animals, hamster, and we saw that there is a desquamation of all the olfactory epithelium for these animals just after the invasion of SARS-CoV-2, and some of the hamster had a quick recovery of the epithelium, but some of them did not add this at 15 days. So we don't really know now. It's difficult to answer this question, but we should. It will be nice if we could take a piece of the olfactory epithelium to understand what happened at the first at the onset of the disease. But it's very dangerous, and I'm not sure if the ethical team will be okay for this. So, but it will help us to know what happened in the cleft at the beginning.
Great. So, Charlotte, thank you very much for those answers, and we come back to you along with the other panelists at the end.
Okay.
So, thank you. So, our next speaker is Professor Rick Gerken, co-director of the ICON Lab at Arizona State University. Dr. Gerken received a BS in chemistry from Stanford before doing his PhD work in neurobiology at the University of Pittsburgh and at Carnegie Mellon. He's been in the field of olfaction for 12 years, researching neurophysiology, human psychophysics, and computational and mathematical models of smell. His current work focuses on olfactory data science, including predictive modeling of smell perception. His talk today is on predicting COVID-19 status from chemosensory phenotype.
Thanks. And if you or Danny knows when the poll results will come through, just fill me in, just jump in and let me know. Okay, great. So almost everyone is familiar with the GCCR survey, which is great news. It means they don't have to spend much time on that. I will briefly introduce that survey, and then I'll skip ahead to the things that I think there's more urgent need to learn about here today. So. So many of you know the survey, right? Many languages, many countries, many people have taken this, about over 50,000 people now. And in the survey, there is essentially three sets of things that we want to learn about. One is about viral status for COVID-19. One is about sort of all the symptoms that we don't consider part of the chemosensory family, the classic symptoms, for example, that the CDC considers to be important or has considered to be important, as well as many other symptoms involving smell, taste, chemesthesis, nasal blockage, and so forth. And the first description of the relationship between these symptoms and COVID-19 was published recently in Chemical Senses. I put the link in the chat. And I think the GCCR team sees this as a descriptive analysis of chemosensory changes associated with COVID-19. And so what we wanted to do in the project that I was more directly involved in is ask, how can we use those to make a prediction about COVID-19? Can we, based on those symptoms, say, yes, you are likely to have COVID-19, no, you're not likely to have COVID-19? And the context here is not so much COVID-19 versus you are completely healthy and there's nothing wrong with you, but it's more COVID-19 versus other respiratory illnesses, because the survey, with the requirement for proceeding past the first couple of questions in the survey, is that you have had a recent respiratory illness. So rather than do you have COVID-19 versus are you just fine, it's do you have COVID-19 versus a cold, do you have COVID-19 versus the flu, do you have COVID-19 versus some other respiratory illness from some other virus or bacteria. That's the thing we really wanted to learn about in this study, especially as winter is coming. Many people will have respiratory illnesses that are not COVID. In fact, probably a vast majority of them will not be COVID. And it'll be important to understand which of those people are at risk for COVID-19 and which are not. So in the study, the raw data was quite large. Some of these were excluded because, for example, there was no prior respiratory illness. In the final sample, that was broken into several categories. For the purpose of this study, we wanted to use the gold standard of a viral PCR test for COVID-19. So the positive and the negative categories here, which is two middle boxes in blue, those are the data that we focused on. Although and I don't show this here, but it's shown in the previous paper and supplemental materials of our paper that the clinical COVID-19 population, which is those people diagnosed by a physician, are actually have a very, very similar chemosensory symptoms to those who obtain a positive result via a viral test. So we're going to focus on the COVID-19 positive and COVID-19 negative population. You'll notice here the COVID-19 positive population is much larger than the COVID-19 negative population, which means it's actually not a representative sample. And I'm going to discuss in a couple of slides how we're thinking about that and how we deal with that. So keep that in mind. And in a later part of the study, we're going to look at also people who have recovered from COVID-19 or if they've recovered and what did their chemosensory profile look like. So the first thing that jumps out is that those people who took the survey, who had COVID-19, reported a more severe smell loss than those who did not. So remember, these people they must have had a respiratory illness, and there's a good chance that they're heard about the survey or are taking the survey because they are interested in chemosensory symptoms. Why might they be interested in these symptoms? Well, possibly because they lost some sense of smell. Nonetheless, the sense of smell wasn't more severe for people with a positive viral test for COVID-19, which is summarized in this breakdown of the data here. These so-called pirate plots or violin plots show one dot for each respondent. And the width of these little enclosing envelopes, you can think of it like a histogram or probability density. So the width of an area is related to the fraction of subjects that are in that category. So on a scale from 0 to 100, people self-reported their sense of smell, and the smell loss was quite severe in COVID-19 and somewhat more mild in cases that were not COVID-19. And you can see a similar result for taste. So the question is, which of these things is a better predictor? What about all these other symptoms? Right? Many symptoms were assessed in the survey. Many were not chemosensory. Which are the most important? So now you've seen you have a great deal of smell loss in this population and a great fraction of people with COVID-19. So what does that then I think immediately suggests how do we handle the problem of selection bias? So I want to discuss that sort of conceptually here. When you have two variables and you want to ask about their association, you want to ask how one predicts the other. How does X predict Y? There's two things that you need to worry about when you're thinking about what do I control for, what do I not control for. So we think about confounders. Confounders are things that influence both X and Y. And because they influence both X and Y, if you do not control for confounders, then you might spuriously infer a correlation or an association or a causal relationship between X and Y that doesn't exist. On the other hand, there's another more often overlooked thing called the collider. The collider is something that both X and Y influence. So if both X and Y lead to an event, that event is called the collider. Colliders you do not want to control for. When you control for a collider, you actually you get spurious associations in the other direction. So, for example, imagine there is a university that admits students according to some threshold, which is the sum of academic ability and athletic ability. If that were the case, you might imagine that there would be some very high achieving academic students and some very high achieving athletes and some people who are sort of in between. If you look at the population at that university, you would observe a negative correlation between academic performance and athletic performance for that reason, even though that was not representative of the larger population in which that correlation may not exist at all. So in specific to this study, you have, for example, confounder might be age. It might be something you control for age. Age is something that could produce COVID-19. It could produce smell loss, and it might do that at differential rates depending on different ages. Younger people may be more likely to have COVID-19. Older people may be more likely to have smell loss independent of COVID-19. On the other hand, the very participation in the GCCR survey is a collider. It's something that is caused in part by getting COVID-19 or getting smell loss for some other reason. So here we actually don't want to control for GCCR, but I do want to identify that it's a collider, not a confounder. What that means is that if there was a positive correlation, positive association, or even a causal relationship between COVID-19 and smell loss, the fact that GCCR is a collider would cause us to underestimate that relationship. If there was no relationship, it would actually cause us to estimate a negative correlation between those two variables. And so when I show you data that shows a positive association, I want you to understand that that's not inflated, that's actually an underestimate. So that's called collider bias, and it's especially in the context of COVID-19 research, people really begin to appreciate this topic in biomedical and human subject research. So the first thing that we did is simply look at binary symptoms. So by binary symptoms, I mean things where you answer a yes or no question, like a checkbox. And so there are many of these. These are not merely chemosensory systems. Here is a full list of symptoms that were examined. And what I'm plotting on the x-axis is a measure of association called Kramer's V. You can think of it like a correlation, but for categorical data. And what we see here is that many of these of the symptoms that were studied have essentially no association with COVID-19 at all. A larger bar means a larger association, means it's more it's basically more correlated with COVID-19 status. And you can see that changes in smell were by far the largest association. Things in red are things that are positively associated with COVID-19. Things in blue are things that are negatively associated with COVID-19. So if you look at something like sore throat, negatively associated with COVID-19. Well, don't people with COVID-19 symptoms get sore throats? They do, but people with colds and flus get sore throats more frequently than people with COVID-19, at least as it present as a symptom that they would report on a list, and so you get a small negative association. But changes in smell or reported anosmia, hyposmia, those are things that are much more likely to occur in COVID-19. So if we want to quantify chemosensory function, you can use a checklist, yes or no questions. But you could also do something different. You could ask people to rate things on a scale, which we did for a subset of the questions. And what you get when you use a full scale versus a binary response, you get a lot more information. So just an example, here's the pain scale that everyone knows if they've ever been in pain and we're at speaking to a physician or a medical provider about getting medication. You rate things on a scale from 0 to 10. And the value of that to the provider is that it tells you how bad is the problem, right? If you just ask people, are you in pain, yes or no, and made a decision about prescribing opiates, that's probably not a very good strategy. But knowing 0 to 10, it gives you a lot more information. Is someone in level 4 pain or in level 9 pain, right? And it doesn't mean that everyone has to answer this question honestly, but if they are answering honestly, you can resolve a lot more information about the degree of the problem. And so when we look at these, when we look at this scale and we use this kind of scale, in addition to the binary questions, to ask how well can we predict COVID-19, we obtain this result. So this is called an ROC curve, and some of you are familiar based on the poll with what this is. But essentially, it asks how well can we predict with high sensitivity, high specificity, or both, our COVID-19 from a set of symptoms. So if the data were on the dotted line, okay, if a set of symptoms produced an ROC curve that followed that dashed line, that would mean it was predicting at chance levels. We are a random prediction of COVID-19 status from the symptoms. In contrast, if a curve you see here went up all the way to the upper left corner and over to the right, so it made a sort of an upside down L shape, that would be perfect prediction of COVID-19. So a perfect prediction, you make no mistakes, you find out a set of symptoms, you can say with 100% certainty if someone has COVID-19 or not. For the actual data, we obtain things like, for example, the blue curve. If we only ask the question, how much smell loss was there during illness, we get data that looks like the blue curve. That says that, for example, if we want to have a false positive rate of 50%, which means we say, okay, the following 100 people have COVID-19, but 50 of them don't, and 50 of them actually do, we can be specific to a rate of about 85%, which is to say that we can exclude, that we can let's see, true positive, false positive rate. Everyone gets this confused. I get this confused every time I look at it. But false positive rate, sorry, is a measure of specificity, and true positive rate is a measure of sensitivity. So if we want to be specific at 50%, we can be sensitive at 85%. If you add more symptoms, you don't really get any better. The only symptom that really helped was knowing a little bit about the time since the onset of the disease, which is shown in the green curve, days since onset. Because a rapid onset smell loss is more predictive than sort of a slow burn. But if you look at a full model that has 70 different symptoms, including fever, including shortness of breath, and so on, you don't really get any better, which is to say, once you know that you have a respiratory illness, knowing that you have smell loss is about the only other thing that you need to know. In a survey, right? If you do clinical examination, that'd be different. Knowing that someone had fever or shortness of breath and so on, it is not actually helpful in distinguishing those who have COVID-19 from those who do not. And this is summarized here. This on the x-axis now we're showing what's called the area under the curve. So it's a measure of how much that curve goes towards the upper left corner. So further to the right in this graph is better. So if you have smell, if the rate of reported smell during illness, or the rate or the amount of change before the illness versus during the illness, is the most predictive symptom. If you go down to these binary symptoms, like simply, do you have smell loss, do you not have smell loss, that's somewhat worse. That's shown in the middle, under the two middle symptoms that are shown there. And by the time you get to something like sore throat, which is actually a negative predictor, it's not so good anymore. And by the time you get to things like fatigue and cough, they're almost not even past, they're not barely above 50%. So I cough every day of my life. I have sore throats all the time. I've never had profound smell loss, right? So this is a very specific symptom of COVID-19. And many others now have shown similar kinds of results using alternative approaches. We saw one earlier today in talk today. There are others from other kinds of surveys. There are ones from case control studies and uncontrolled studies, and all sorts of things, showing that anosmia is a single best predictor of COVID-19. And it's actually sort of shocking that we persist in using fever guns and symptom checklists that do not emphasize the sense of smell, where they might help screen out people with COVID-19 and people who have colds and flus, which might be perfectly fine. But if you want specific information about COVID-19, smell loss is really the way to go. So one more slide about smell loss. We observed really three groups. Those who had no smell loss, which is a very small fraction of the population, probably an underestimate of those who have no smell loss, which might be, say, closer to 50% of the population with COVID-19. But among those who lost their sense of smell, about half still had smell loss at the time they took the survey, and about half had recovered their sense of smell. So we looked at the time course of this, and we found, and just focus on the gold curve here. The gold curve is how much on a scale of 0 to 100, how many points had they recovered in smell loss on average as a function of days since the onset of their disease. So some people recovered it very quickly. It was rapid smell loss and rapid recovery. And then you see a sort of climb up to about 30 days. And past 30 days, you're not really seeing very much, which suggests that there is some fraction of the population which at 30 days still has persistent smell loss, and didn't seem to have gotten back. And if you look at this data in terms of the fraction of people who recovered any recovery at all, it actually looks very similar. So about half the people had not had recovery at 30 days, and eventually we would like to follow up with these people and find out where do they stand 3 months, 6 months, 1 year out. So the final take home we got from this is that the rating of smell during illness on a scale of 0 to 100 was strongly associated with the probability of having COVID-19. So once you get to smell 0 in our sample, which is enriched in COVID-19, it was extremely likely. But what we really want to know is not the probability of having COVID-19 in our survey. We want to know about the probability of having COVID-19 in general. And for that, we can use an odds calculation. So the odds of having COVID-19 were much higher. The odds ratio is something that's going to generalize to a different sample. The odds ratio I show stylized in this plot, but essentially the blue line is showing you what you saw in B in a cartoon form, and the red line is what an odds ratio would look like, when an odds ratio for something that is not a predictor is by definition 1. So only for sort of severe smell loss below 30 on this scale do you see an odds ratio above 1 of COVID-19, which climbs to about 10. And other groups have estimated odds ratios anywhere from 5 to 50 for the same symptom. So this produces a clinical scale that can be used, and the clinical scale looks like this. Do you have a previous smell or taste disorder? If you do, don't use this scale, because this scale is for people who have novel smell loss. Then rate your ability on this scale from 0 to 10. So it's just like the pain scale, 0 to 10. 10 is you have great sense of smell, 0 is you have total smell loss. If you get a number below about 3, which would translate to 30 on our original scale, that suggests a weak odds in favor of COVID-19. And as you move down the scale towards 0, the odds get stronger and stronger towards 10 or possibly more. And so if you have a scale of 3 or lower, that's a moderate to high risk of COVID-19. And we believe that because we understand this collider bias, and because we understand odds versus odds ratios, that this is actually a number that will generalize to a larger population. So I'd like to thank basically everyone in GCCR, but there's too many to name, so I'm just going to single out Valentina, who worked closely with me on this work, and of course all the rest of the GCCR leadership team, and all the people who came forward in March and April and May about smell loss as a symptom for COVID-19. These are the people who put this on the map, and we've just carried this forward to try to quantify it. I'd also like to thank my funding agencies who have been very favorable to researchers taking a break from the research they normally do to focus on COVID-19 related research in their field, which I think has been very, very good. Thank you.
Thank you very much, Rick.
Rick, could you stop sharing your screen, Rick?
Great. And Danielle, would you like to take perhaps 2 questions now, and then we'll take more in the general discussion?
Absolutely. So I don't see any questions directly for Rick in the question and answer panel.
I can see one.
I see
Nicole Garnier. Rick, is this also shown in kids, anosmia as the primary predictor? If so, how can we think about adapting the simple smell questionnaire for kids?
I'd like to know the answer to that. I actually get that. I've gotten that a few times. This survey here is excluded people under 18. And there are many reasons people choose in humans research to exclude subjects under 18 for ethical reasons, for reasons of getting consent, for reasons of understanding the instructions, which is a shame because, you know, if, for example, I'm sending my kids back to school in 12 days. I would love it if they could have a smell screening when they get there. And I've made this, the school officials aware of this as an important symptom, but they don't really have a great way of measuring this. And we certainly hasn't been validated in kids. So we don't actually know the answer to that.
Okay, so that looks like we'll probably have questions more toward the end. So let's move to our next talk here. Bear with me while I share my screen.
Hello everyone. First of all, we would like to thank the GCCR to give us the opportunity to present our work entitled Self-Reported Smell and Taste Loss are Early Markers of the COVID-19 Pandemic and of the Effectiveness of Political Decisions. Please feel free to contact the corresponding author if you want to get more information on this work that has been submitted to Nature Communications. As you know, the COVID-19 pandemic is characterized by a high number of deaths, but above all, COVID-19 has led to an explosion in the number of patients admitted in the intensive care and critical care resuscitation units, leading to possible bottlenecks. So much that in France, in the United States, as well as other countries, the army had to install temporary hospitals in the heart of cities. Faced with this disease, it was necessary to react quickly to avoid reaching the bottleneck of health systems. In order to limit the sorting, that is to say, prioritize some patients at the expense of others due to lack of resources, and also to avoid endangering healthcare staff again by the lack of resources. The first step was to offer people to adopt barrier gestures, and this in order to flatten the curve under the capacity limit of the GCCR units. But to preserve the healthcare system and staff, we had to quickly put in place more extreme means, such as general lockdown of the whole population of the GCCR units. But to preserve the healthcare system and staff, we had to quickly put in place more extreme means, such as general lockdown of the whole population. These measures quickly had significant economic effects, but also social effects by preventing, for example, from participating in funerals, or by increasing the isolation of the elderly, and by increasing the risk of intrafamily violence. We still don't know what the effects of these long-term measures will be, especially on children and on chronic disease patients. After 3 months of lockdown, it was therefore imperative to reopen the countries. So, the governments needed reliable tools to monitor the level of pandemic on their territory. As of May 7th, the French government has categorized each department in red, yellow, or green, based on resuscitation capacity of the hospitals and an indicator of the circulation of the virus. The latter is defined by the number of suspected cases of COVID-19 in the emergency rooms. However, this indicator is limited by the fact that many symptoms are common between SARS-CoV-2 and other viral infections. At the same time, several studies have shown that SARS-CoV-2 infections can cause loss of taste and/or smell. Those symptoms have been identified even as the most characteristic symptoms of the infection. As you know, the GCCR consortium brought together more than 500 researchers spread all over 50 countries and work in particular on the distribution of a global survey. This survey is currently available in more than 30 different languages. Globally, the general public is invited to register and report symptoms related to the potential COVID infection. In France, this survey had significant media coverage. More than 5,000 French people have reported a taste or smell disorder through this intermediary. We therefore wonder if these reports of loss of taste or smell allowed us to follow the pandemic. To do this, we cross-reference our GCCR data with the data available via public health in France, and in particular, the daily number of entries in the intensive care units linked to COVID-19. The relationship between self-reports of changes in smell and taste by French residents diagnosed COVID-19 positive or not, and the estimators of local healthcare stress was evaluated using a geographical approach. And we observed that a large part of the participants, here the blue dots, lived in areas classified as red by the government, that is to say, affected by the epidemic. By comparing the different French regions, we observed a strong correlation between the number of admissions to GCCR units and the reports of taste and smell disorders on the survey. Interestingly, the correlation between the loss of taste and smell and admission to GCCR units is much stronger than the obtained with the marker used by the government at the regional or departmental level. Then, we analyze the temporary dynamics by studying the dates of onset of the first symptoms, and more precisely the date of change in taste or smell. We observed that the majority of participants reported the first symptoms between week 9 and 14 of the year 2020, that is to say, during the month of March, with increased loss of smell here in blue until March 21st, and then a rapid decrease in cases. Our results confirm that olfactory losses are felt about 3 days after the first symptoms. But even more interestingly, the olfactory losses appear 4 days after the start of the lockdown, which suggests that the participants were mainly contaminated before the start of the general lockdown. One may wonder if this temporal dynamic is specific to the participants of the GCCR survey, or if it really represents what happened generally in France. For this, we use Google Trend tools, which allow to follow the Google request of the French people. And we observed that at the same time that the participants declared the first symptoms, histogram in blue, there was a peak of requests on Google browser for the words fever, cough, and a few days later, aches. 3 to 4 days later, the French people searched on Google for the words loss of smell and loss of taste, at the same time that the GCCR participants declare their loss of smell. Finally, 10 days after the beginning of the lockdown, there was a peak for requests concerning a later symptom of the disease, which is breathlessness. This peak is concomitant with the massive admission to intensive care units in France. All these results suggest that part of the French patients follow the same temporal dynamics, and the majority got infected just before the lockdown, and we are therefore witnessing a synchronization of symptoms which make the wave visible on Google. We can see that the peak of changes of taste and smell a few days later, the start of the lockdown, actually highlights the positive effect of the lockdown, since there is a significant decrease in the rate of the new cases admitted in CCR units. But it may also be part of the spread of the virus from the last weekend before the lockdown, where elections, crowded restaurants, and crowded shops took place. In any case, the peak of loss of taste and smell precedes by 10 days the peak of admissions in CCR units. It should be noted that the government indicator does not begin to decrease until 7 days later. Following these results, and after having replicated this result with data from Italy and UK, we therefore propose that monitoring of smell and taste disorders can be an effective tool to detect the spread of the virus by detecting future outbreaks, informing on the effect of political sanitary decisions, and predicting future pressure on hospitals using a tool highly cost-effective, minimally invasive, and reliable. Being able to predict future pressure in located regions with sufficient time may help anticipate new peaks and help to allocate the necessary resources. We believe that these characteristics can make the self-reporting of smell and taste disorders a crucial tool for detecting the next waves, especially in winter when many viruses can cause similar symptoms. Thanks a lot for your attention, and please do not hesitate to contact us. Bye.
Great, thank you very much. And we have one of the authors of that paper with us, Dennis. So do we have any questions? Using the Q&A panel, please, at the bottom of your screen.
At the bottom of the...
Let me see.
Yeah.
It looks like if Charlotte is still on the line, it looks like some of our questions
Yes.
for this general
Yep.
period. If you don't mind taking a few questions, we'll have questions for all the panelists. So one of the questions, Charlotte, is a question about the sample size. And the question is the sample size of the MRI study enough to draw a conclusion? Charlotte.
Sorry. Just so someone talked to me in the same time. Can you repeat? Sorry.
The question is about sample size, and is the sample size of the MRI study enough to draw a conclusion?
So what was important for us was to perform MRI to few patients and control 1 month later. And it was not so easy to perform the MRI at the onset of the disease because we had to perform the MRI ourselves with Michael. The technicians didn't want to put the patients who were highly infected in the MRI. So we could not, it was not possible to do this for more patients. We had to choose, and we choose to perform it we perform it for 25 patients, but 5 patients did not come back, 1 month later. So we just published the work on 20 patients. What was important is that we follow around 400 patients, but most of these patients didn't add the MRI at the first time, at the onset of the disease. And we can see in the study we performed that the obstruction of the cleft quickly disappear for most of the patients. But if you perform the MRI at the early stage, you can see it. You have to do it in the 11 first days.
Charlotte, thank you. So the next question is for Dr. Dennis, the last speaker. The question is from Nicole Garneau, and she asked, how is this information about smell loss as a predictive quality for COVID, I'm just interpolating a little bit, being communicated to governments? You'll need to unmute yourself. How is this information being communicated to governments?
This is a very good question. we are actually trying to communicate that to the agency, to the health agency, and trying to tell them that self-report and self-testing could be interesting. But now we have some limitation because in France it's not yet. I mean, the government didn't know where is the limit between personal information and can we create a registry and ask people if they are sick or not? And this is a big question. They are very afraid about privacy questions. And for example, we try to ask in the university if the student have could suffer of loss of smell, but the authority are very afraid that this is not okay to ask to the student or to the worker here, and to have some kind of register about the loss of smell. So we face ethical and legislative problem in France, actually. So this is where we are now. And in France, we are in the middle of the second wave. We don't know yet if it's a second wave or not, but something is going on. And the government still don't know what to do with this kind of information.
Thank you for that answer. So we'll just wrap up with one very tricky question. This is also from Nicole Garneau, and I will direct this to Rick. So Rick, you'll want to unmute yourself, and here's the question. How do the predictive measures around smell really map on to whether people are actually infectious?
So I wish we knew more about the exact time course of each symptom. In the GCCR survey, we did not really learn that. It was not set up to learn exactly that. I think there are other studies that will find that. Anecdotally, I know people who say, I was 100% fine. On day one, I felt a little tired. The next morning, I woke up, I had total smell loss. So it can certainly happen early in the disease, but I think there's no guarantee that would happen. The earlier it happens in the disease, the less likely the person would actually be, it's by the time it's the onset of symptoms, they actually probably are infectious, right? So ideally you want a symptom measure that occur early enough that you catch them while they're infectious. If they got this smell loss at the tail end of the disease when they maybe weren't infectious anymore, it wouldn't be so helpful. So the hope is that it's early enough in the disease.
So I will wrap the questions up and turn it back over to Dr. Wyatt.
Thank you to all our speakers, to Professor Reed for organising this afternoon's event, for everybody for participating with your questions and your observations. And I've put the link to the GCCR site in the chat. If you want to get involved, do click on that and click membership. Thank you very much for joining us today, and happy travels. Thank you. Bye.